Hello, everyone, and welcome. I'm Shelley Gunther, sonographer and clinical marketing manager at Clarius. We're very excited to see so many of you joining us here today for the live webinar titled Facial Ultrasound Anatomy, Evaluating Skin Layers, SLEB for Dermal Issues and Key Facial Structures. I'm very happy to welcome back imaging expert Dr. Karina Ravera to talk about facial ultrasound anatomy in detail, giving you more tools that you can use in your aesthetic practices. You're among just over 2,000 avid learners who are registered for today's popular event. Thanks so much for joining us from all corners of the world. Dr. Ravera actually presented this webinar in Spanish a few days ago, and we're very grateful for her willingness to accommodate us in English today to demonstrate her amazing wireless ultrasound techniques. Dr. Ravera will show just how easy it is to identify important facial structures and layers to help you achieve safer, better outcomes for your patients. And we'll also see some live scanning with the Clarius L20 HD3, including a demonstration of T-mode following Dr. Ravera's presentation. Now, a quick housekeeping note, please use the Q&A icon at the bottom of your screens at any time during today's webinar, and we'll have a live Q&A session with Dr. Ravera following her presentation. Now, I have the pleasure of hosting the webinar today, and just before we start, I'd like to share a couple of papers relevant to today's topic. Great. Now, this paper talks about new applications for ultrasound use that include dermatology and aesthetic medicine. As we know, in aesthetic medicine, high-frequency ultrasound is applicable to support filler injections, measure dermal thickness before aesthetics procedure, or monitor treatment results. The authors also discuss ultrasound use for skin aging assessment, and Dr. Ravera will be showing us some skin ultrasound in her presentation, so you'll be able to see the value of learning ultrasound anatomy of the layers of the face, including the skin. And the next paper, according to the research proposed in this study from Skin Research and Technology, several skin changes caused by aging can be observed with high-frequency ultrasound. Now, dermal echogenicity on ultrasound changes with age, and also the presence and dimensions of the SLEB can also be evaluated, which Dr. Ravera will discuss today. Knowing all of these things could mean better outcomes for your patients. So just before we start, a quick poll before I introduce our guest. Now, we'd like to have an idea of how common ultrasound use is among attendees. So do you use ultrasound in your practice currently? Just let us know how often or even not at all. Good, and we'll close the poll out in 3, 2, 1. Great. Okay, so a lot of you are using it daily, mostly occasionally, and there's a few of you that are still holding out and not using it all. So hopefully we can change your minds today with the information that we have. Good, so now I'd like to introduce our wonderful guest speaker, Dr. Karina Ravera. She's an aesthetic radiologist and educator from Argentina, and she brings more than 25 years of experience in her field. Dr. Ravera is medical director of Ultraskinis and director of Dermica Academy in Latin America. Dear Dr. Ravera, welcome back and thank you for joining us. I will hand the presentation over to you now.
Hello, Shelley. Thank you for your presentation and for the invitation. So let's begin with this topic. I am radiologist, I am postgraduate in aesthetic medicine, and I see these topics of facial anatomy very important for us in our daily practice. So I will talk about ultrasound anatomy, SLEB, superficial and deep fat compartments, SMAS, and bony surface and foramina. So first of all, let's see about technical aspects. We will use linear probes, for example, Clarius L20 or L15. We will apply a generous amount of gel. We will scan the skin very softly in order to avoid apply an excess of pressure on soft tissues, in order to prevent anatomical distortions, reduces artificial thinning of the layers, and avoid compressing vascular structures or lesion if they are present. So the skin is composed by epidermis, dermis, and hypodermis. The epidermis is the outer layer. It contains high keratin amount of a high content of keratin. Sorry, the thickness is approximately 0.06 to 0.6 millimeters, and in under ultrasound examination, it will looks like a hyperechoic line. The dermis is the intermediate layer. It is rich in collagen and elastin, and the thickness is approximately from 1 to 4 millimeters. And in ultrasound examination, the papillary or superficial dermis will be looks hypoechoic or in medium gray, and the deep dermis or reticular dermis will look hyperechoic. The hypodermis is a deep layer, and because the high content of adipocytes and fibrous septa, it will appear like a hypoechoic imaging with the fibrous septa like hyperechoic lines. This is the retinacular cutis. And now we have to know about the basic nomenclature and the classification of the echogenicity. Echogenicity is the ability of a tissue or a structure to reflect ultrasound waves during an ultrasound examination. So a lesion on a structure that is hyperechoic will look white, and hypoechoic structure will be in gray color, similar to the adjacent tissue. And a hypoechoic structure will look dark or gray. Yes? And an anechoic structure will look black. So the echogenicity of each layer depends on its main component. Yes? Epidermis, because the high keratin content will look hyperechoic. The dermis in general, the superficial dermis, will look hypoechoic. The deep dermis hyperechoic, and the hypodermis, because the content of fat lobules, will look hypoechoic. Yes. So in this image we can observe a normal skin image of the skin. This is a high resolution ultrasound image. I have done this image with my Clarius L20, and we can see the shell, this hyperechoic line that corresponds to the epidermis. Here, this hypoechoic band corresponds to the superficial dermis. This hyperechoic band corresponds to the deep dermis. And finally, we can observe here the subcutaneous tissue, hypoechoic, with these white or hyperechoic lines that is the retinacular cutis. So with high-resolution ultrasound is the imaging technique that most closely resembles the histological images of the skin. And now we can observe again the epidermis, this blue line. This is the epidermal junction. This is the superficial dermis, the deep dermis. This line corresponds to the hypodermal junction, and finally we can see here the subcutaneous tissue. So if you have a Clarius L15, you can see the skin with a special preset for dermatological studies, and you can see the epidermis here, this white or hyperechoic line. This is the superficial and deep dermis, and lastly the subcutaneous tissue. Again, we can observe or identify very well the epidermis, the superficial dermis, deep dermis, the subcutaneous tissue, and here the dermoepidermal junction. We can observe here very well the differentiation between the superficial and deep dermis, and finally, we can observe here the dermohypodermal junction. And now let's talk about the vascular supply of the skin. We have the superficial plexus located in the superficial dermis, a deep plexus located in the deep dermis, and finally the main vessels located in the subcutaneous tissue. And now we can see these different images because the skin varies across the different areas of the face. The differences are because the skin has different thickness, dermoepidermal ratio, and hypodermal thickness. So in this image, we can observe this image that corresponds to the frontal area, and we can observe the epidermis, superficial and deep dermis, and the subcutaneous tissue. And here we can observe in this image that corresponds to the cheek, and we can observe a very thick subcutaneous tissue. And this image corresponds to the nose area, and we can observe the epidermis, a very thick dermis, superficial and deep dermis, and here we can observe the cartilage. And in this case, we can observe this image that corresponds to the periorbital area, and we can see the skin again, the subcutaneous fat, the orbicularis oculi muscle, and finally the deep fat and the surface of the bone. And this is an image that corresponds to the submental area, and we can identify very well the different tissue layers. And the skin varies also in each area of the face because we can observe different differences in the thickness. The thinnest skin is located in the upper eyelid. The thickness is approximately 0.5 millimeters. And on the top of the nose, on the tip of the nose, we can observe a very thick skin that approximately measures 2 millimeters. So this is very important in order to assess treatments or, for example, plan surgeries, etc. This is very, very important. And what happened with the scalp? We can also analyze or identify very well the different tissue layers. This is the epidermis, the superficial and deep dermis, and these tubular hypoechoic structures correspond to the hair follicles. And if we can identify in which layer these hair follicles are located, we can deduce in which phase they are living. For example, in the telogen phase, the hair follicles is in the dermis, and in the anagen phase, the hair follicles will be located in the hypodermis. This is a very important data for treatments of the scalp, for example. And we have differences in hair thickness and number of hair follicles in different regions of the scalp. In the frontal region, we will see thinnest hair follicles, and we will be less in number. For example, if we compare to the occipital region. And now we can observe this image that corresponds to the glabrous skin located in palms and soles. And we can observe the three laminar image that correspond to the outer layer is a very hyperechoic and thick layer. The intermediate layer is hypoechoic, and finally the inner layer is hyperechoic and thin. And it features an additional epidermal layer, the stratum lucidum, located between the stratum granulosum and the stratum corneum, composed of nucleated transitional cells. So the first step in interpreting an ultrasonographic image is to recognize the anatomical structures that make up the scanned area. And now I will talk about the SLEB, subepidermal low-echogenic band. The SLEB is an ultrasound finding that doesn't represent a specific anatomical structure, but rather reflects a functional and structural alteration of the papillary dermis. It appears as a hypoechoic band beneath the epidermis on high-frequency ultrasound. SLEB is an acronym that tells us where it is located and how it looks. At the molecular level and histological level, the SLEB is associated with the following changes: a decrease in type 1 and type 3 collagen fragmentation and disorganization of collagen fibers in the papillary dermis, reduced fiber density leading to decreased reflectivity, increased water content due to interstitial edema because acute and chronic inflammation, chronic inflammatory infiltrate. We can find lymphocytes and mast cells, especially in chronic dermatitis such as atopic dermatitis, eczema, psoriasis, among other conditions. We can see increased vascular permeability, edema, degeneration due to actinic damage, for example, because photoaging, where we will find solar elastosis and accumulation of amorphous non-fibrillar material because the presence of abnormal proteoglycans and glycosamine glycans, because the fibroblast is or has an abnormal metabolism, and it cannot do the correct washout of these molecules. So SLEB is a very important ultrasonographic biomarker. It is objective, valid, and reproducible. It is very important in skin aging assessment, atopic dermatitis, psoriasis, cutaneous lymphomas, lichen, and others conditions. So, for example, in this image, we are assessing the skin aging, so we have to take in account that the SLEB may be considered like a ratio. So we have to divide the SLEB by the total dermis thickness, and after many treatments or different treatments, for example, the SLEB has to decrease and or the total dermis may increase. So I will talk something controversial. The skin aging may have a number. This is, in my idea, very important. So we can observe here the SLEB, this hypoechoic or anechoic band located beneath the epidermis. And here we have a clinical case with a man with photoaging, and we can see this diffuse located SLEB. The SLEB is located very diffusely on the face. This is the anechoic or hypoechoic band. Yes, this red arrow is signaling the SLEB. And this is another clinical case, lichenoid dermatitis. We can observe different areas in this lesion. This is a very inflamed area of the lesion, and we can observe if we translate this pathology on ultrasound examination, we can find or identify very well the hyperkeratosis and the SLEB. Here we can see inflammation, subclinical inflammation. And I have colored this image to understand much better the hyperkeratosis and the SLEB inflammation in this case. And if we compare clinical features and ultrasound features, we can observe in this area where the patient has more inflammation, we can observe under ultrasound examination this hyperkeratosis and the SLEB. In this case, the SLEB is very thick, and in this area where the patient has less inflammation, the SLEB is thinner. And here in this area, the SLEB is practically absent because the patient in this area hasn't got inflammation. And let's see now atopic dermatitis. We can observe here this inflammation in the skin, and histologically, we can observe these immune cells located under the epidermis, and the translation with ultrasound is the SLEB. This is inflammation in atopic dermatitis. And in this case, we can observe the same inflammatory cells located under the epidermis. And in this area where the skin is normal, we cannot see these cells. So that's why we can analyze very well the distribution of the inflammation under ultrasound examination. So now let's see superficial and deep fat compartments and the SMAS. So under ultrasound examination, we can observe every tissue layer that compounds the maxillofacial tissues. We have seen about the skin, we have talked about the skin, and now I want to talk about superficial fat compartments. We can divide or classify the superficial fat compartment in non-periorificial or type 1. This fat compartment has large white adipocytes, and periorificial or type 2 fat compartment, it has mature adipocytes. So in non-periorificial or type 1 fat, we will see this type of fat like hypoechoic image, and the periorificial or type 2 fat will look hyperechoic. And we can observe in this hypoechoic or type 1 fat that is looser and more mobile. It has less adhesions or less retinacular cutis. And the other fat, the type 2 fat, has stronger adhesions and very little lobules of fat with a dense retinacular cutis organization, and it is less mobile. And let's see this difference between the periorificial fat or type 2 and this non-periorificial fat on MRI, on this actual MRI view. And on CT, we can observe differences on periorificial and non-periorificial fat, and we can translate in this fat on ultrasound images, and we can observe the skin, the epidermis, superficial and deep dermis, and we can observe this hypoechoic fat. And here we can observe this periorificial image of the mental area, and we can identify very well the epidermis, the dermis, and the subcutaneous fat that it looks hyperechoic. Yes, this is a longitudinal view of the mental area. So let's see now the frontal area, and we can distinguish very well in this longitudinal view. This is superior and this is inferior, and we can identify very well the epidermis, superficial and deep dermis, subcutaneous fat, hypoechoic. This is the epimysium, this white line, and below we can observe the frontalis muscle. And finally, this hyperechoic line that corresponds to the frontal bone. And in this axial view, we can see every structure, also the epidermis, superficial and deep dermis, subcutaneous fat, the frontal muscle, and finally the bony surface. And in this image, we can observe the temporal area. So in this longitudinal view, we can distinguish very well also in this B mode ultrasound image the different tissue layers of the temple. But with T mode, we can differentiate very quickly the different tissue layers, because with T mode, is a AI preset that, or tool, for example, that color and texturizes very well the different structures of the temple. So I can see here very well the skin, the superficial fascia, the deep fascia, the deep fat compartment, and the muscle, and finally the bone. And here we can see the opacity mask of the T mode, where we can increase or decrease the opacity to a better understanding of the anatomical examination. This is a CT, and we can compare to with the ultrasound images. So the best, the gold standard for soft tissue assessment is the ultrasound, high resolution ultrasound. This image corresponds to the cheek. This is an axial view, and we can identify the skin, the superficial fat, the SMAS, the deep fat compartment, and finally the bone. And this is the tissue mode image. And now we can observe this lateral view of the preparatory area, and we can observe in this axial view the skin, the subcutaneous layer. This is a hypoechoic band. This is the parotid gland in an axial view, the masseter muscle, the buccal fat pad, and the surface of the mandible. And this is a longitudinal view where we can observe very well the different tissue layers, the skin, subcutaneous fat, parotid gland, masseter muscle, and the cortex of the mandible. And we can observe in this CT axial view the different tissue layers, and this cadaver examination of Dr. Leonard Minelli, and we can deduce that in real time, in a live patient, the best option to analyze images of the soft tissues is the high resolution ultrasound. So we can observe finally this axial view of the region of the masseter and parotid gland, the different tissue layers: skin, superficial fat, parotid gland, SMAS, masseter muscle with the divisions, and finally this hyperechoic line that corresponds to the bony surface. And now we can analyze very well the superficial, the superior and inferior lips. This is an axial view or transverse view. And with the tissue mode, we can observe very well and quickly, we can differentiate the anatomy. This is the skin, this is the dry mucosa, the wet mucosa, they are the teeth, and so on. This is the pars medialis of the orbicularis oris muscle, and this is the pars peripheralis. We can analyze very well the microanatomy of the lips. And in this view, we are seeing a longitudinal view of the mental area, and we can observe the skin, the epidermis, the dermis, the subcutaneous tissue, hyperechoic, and the mentalis muscles. And finally, this white line corresponds to the bony surface. And in a more parasagittal or lateral view of the midline, we can see in this axial view of the face, we can observe the skin, the subcutaneous tissue, the depressor angulioris, and the depressor labii inferioris, and the bony surface of the mandible. So now let's see the bony surface and foramina. In the maxillofacial bony structure, we can find by ultrasound from 4 to 10 foraminas because they are very variables and inconstant. So we can find foramen and notch. For example, let's see first of all the supraorbital foramen and the supratrochlear foramen or notch. We can observe the notch here and a foramen here. And with ultrasound examination, we can find this foramen. And if we have a foramen or a notch, we will have a bundle, a neurovascular bundle. And I want to highlight that this area is one of the most dangerous zones in the face because our patients can become blind. And these arteries or bundles are the most variable in our patients. Yes, that's why the ultrasound examination is very important. In this case, we have a notch, and in the other side, we have a foramen. The variations are the rule. Let's see these differences in this patient. In one side, it has two foramina, and in this case, in this side, it has only one. See? So we can observe here again the different locations of the supraorbital foramen. So aspiration and injecting a small amount of fillers is not very safe. I prefer prevention, and we can prevent if we can see the vascular structures, of course. So we have a very laterally positioned supraorbital foramen. And now let's talk about the zygomaticofacial foramen. This is a very little foramen located in the lateral side of the zygomatic bone. We can observe one in this patient, two in this patient, and two larger in this patient. So let's remember that in this foramen, we will find the zygomaticofacial artery that is a branch of the ophthalmic artery. Yes. So now I want to share with you this clinical case. This patient had an orbital vascular adverse event after HA injection with needle supraperiostically. He had an ischemia of the lateral rectus muscle and lacrimal gland. He came to my office with diplopia and cervical pain. We can observe the problem here. He had an obstruction of the zygomaticofacial artery. And here we can observe how the lateral rectus is paralyzed. He had also dry eye, pain. And here we can observe the MRI. The lateral rectus is with a hyperintense signal, and also, of course, with the lacrimal gland. We can find these signs of important inflammation. The pathophysiology is that the zygomaticofacial artery and the lacrimal artery were blocked with hyaluronic acid. So let's see the variations, the anatomical variations of these zygomaticofacial foraminas. In this patient, it has 4 foraminas, and in this case, we can observe 5 foraminas. They are very, very variable, and in some cases, we cannot see any foramina. And now, let's talk about the infraorbital foramen. In this case, we can observe the skin, the subcutaneous fat, the orbicularis oculi muscle, finally the subcutaneous fat, and here we can observe the infraorbital artery. This foramen also has variations. In this patient, we can observe in this side a large foramen. And in this patient, we can observe a double infraorbital foramen. And we can observe another patient with a double infraorbital foramen in this side. So, ultrasound examination with Doppler or B-mode, for example, will help us a lot to prevent vascular accidents. So in this case, we are seeing a CT 3D reconstruction where we can observe very well the foraminas, but ultrasound with Doppler, with color Doppler is the better option and a quick option. And now we can see the mental foramen. They have different locations and number variations and orientations. And in this duplex ultrasound, we can observe the mental artery here. And here we can observe a double mental foramen. We will have 2 mental arteries, 2 bundles in this case. And in this article, we can observe this lateral, this double mental foramina. And in this case, this patient has also 2 foraminas, but located vertically, and in this case, they are located horizontally. That's why high-resolution ultrasound allows us to visualize the bony cortex. This is very important. We will see the bony cortex in a hyperechoic, like a hyperechoic line, so we can detect fractures, cortical lesions, osteosynthesis material, etc. But we can observe the number of foramina and their orientation. So the only way to account for variability is to use imaging, in this case, ultrasound examination. So anatomy. In anatomy, the variations are the rule. And to conclude, facial ultrasound has become an accessible and invaluable tool in modern aesthetic practice. Its use allows us to visualize each patient's actual anatomy before, during, and after procedures, resulting in a more effective, safer, and more precise treatments. Having this individualized anatomical insight significantly raises the standard of care, especially in procedures that involve a higher degree of risk. Without a doubt, the ability to see through the skin in a non-invasive way has profoundly transformed the way we plan, decide, and act in aesthetic medicine. Thank you.
Amazing, Dr. Rivera. Great slides. It's nice to see the correlation between the CT images and the ultrasound images. That was a great presentation. Once again, Janae and I have learned so much more about facial anatomy, particularly the variations in the facial foramina. So now I'd like to introduce sonographer Janae Smith and her beautiful model Anna to show us some live scanning with the Clarius L20. Hi, Janae.
Hi, thanks, Shelley, and thank you, Dr. Rivera. For today's live scan, I'm going to be using the L20 scanner, and I've already set myself up on the aesthetics preset. And I'm going to be starting on the patient's cheek. So from the aesthetics protocol on the bottom here, I'm going to select cheek. And I'm going to start in a transverse orientation here. And we're going to have a look at the different fat compartments of the cheek. So here we can see we've got the subcutaneous fat showing up hypoechoic here. This hyperechoic band is the SMAS. And then here we can see the deep fat components here. And to further accentuate these different layers, we can utilize our T mode. So on the bottom left-hand corner of the screen, we're going to select the modes menu, and we'll select T mode to turn that on. And here we can see a side-by-side representation. On the left side, we can see the B mode, black and white image. And then on the right, we see a graphical representation of the different tissue types and the tissue layers. So it really accentuates those different layers. And when we select the freeze button, all those layers are automatically labeled for us. We can go live again here. And if we select this teardrop AI icon and AI opacity, we can increase or decrease the masking overlay on the B mode image. So it really draws out those different tissue layers for us. All right.
And
so
I think
now,
there was, sorry, Janae, I'm just going to interrupt you for a second.
Please.
There was a question in the Q&A about the muscle and the fat pads looking very similar on many of the ultrasounds. So I think T-mode would be a really good way to start learning the difference and appreciating the difference in those layers.
Yes, some of them are very similar, so it really does help.
Yeah, thanks.
All right, so we'll move on, and we're going to select the eye icon, and we're going to have a look at that infraorbital foramen and the arteries. So we're going to start here beneath our patient's eye, and we can see the bone. Here is that bright white layer. We'll turn on our color Doppler, and we can see the foramen. There it is.
Yes.
We can see the vessel
Nice.
show up nicely right there. All right, so we'll move on to the supraorbital foramen. We'll come up to this side here. We'll get rid of some of our depth. And we can see the foramen right here, and then the other one on this side here. I'll turn the color Doppler on. There it is, nice. Very light touch with this one. So that's the vessel there. Shows up nicely. All right, and we'll have a look at the chin now. So we'll look at that for that mental foramen. And so you can see the bone there. And we can see the foramen, the break in the muscle right here. So I'll turn the color on. Yes. And we can see the vessel nice and clearly right there.
when we see an interruption on the bony surface, we have to try to find the vessels, because we will find the foramen, like an interruption of the cortex.
There we go.
So we can always assume that if there's a foramen, there's going to be a vessel.
Yes, always when we see a foramen, we will find a neurovascular bundle.
Okay.
Sure arteries.
Okay. And then here, just a bit more laterally on the cheek, we can see the DAO muscle shows up nicely here. So it's a very superficial, it's this hypoechoic muscle here that we can see and assess.
Yes, the DIO and the depressor labii inferioris. The main foraminas in the face have neurovascular structures, but sometimes the bones have accessories foraminas, and in their very little foraminas, we can find only arteries.
Okay. All right. There we go.
Great. Thanks, Janae.
Thank you.
Amazing. So I also want to let everyone know that we didn't see any live scanning by Dr. Ravera, but we have a bunch of recordings of her scanning those areas. So you can see some live demos, and that's all on our Clarius Classroom. So if you want to just go to our website and visit the Clarius Classroom, you can see some really good demonstrations by Dr. Ravera there. So great. All right. So as you can see, T-mode just might be the tool you need, that little nudge to get you started recognizing different facial anatomy with ultrasound. Now, just before we open the floor to questions with our guest speaker, here's a quick poll for you. We'd love to really help everyone continue your journey into bringing ultrasound to your aesthetic practices. So please complete this poll if you'd like any additional information. I'd like to take a few minutes to tell you a little bit more about the Clarius L20 HD3, the world's only high-frequency ultrasound in a 20 megahertz wireless scanner. Now, it's 30% smaller and lighter than our previous generations with an integrated battery, and it's available in several countries worldwide. And with membership or the one-time license, you can have access to educational T-mode as well as some other advanced features, AI features as well. So we all know that traditional ultrasound systems are costly and difficult to learn and to use. And Clarius Ultrasound has changed the game, particularly in facial aesthetics. Miniaturization and innovation with handheld units means that high-frequency imaging is now easy and affordable, with image quality that really rivals traditional ultrasound systems, but at a fraction of the cost. The Clarius L20 HD3 is the only handheld ultrasound with the high frequency of 20 megahertz for exceptional superficial imaging, which makes it ideal for facial aesthetics and dermatology applications. And with high definition of the skin, muscles, vessels, and the fascia, and the foramina, you'll be more confident with your needle placement, easily characterize and evaluate fillers, and accurately treat complications, improving patient safety with consistent treatment outcomes. And as you saw during the webinar and live demo, Clarius is wireless, freeing up space with zero footprint. It's also fully immersible and so much easier to clean and disinfect. And only Clarius delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android devices with free updates. Clarius Cloud is available to capture and manage your exams from anywhere. And we also offer Clarius classroom videos with experts and onboarding with Clarius clinicians to build your ultrasound scanning skills. Now, we will close off this poll. And if you didn't get a chance to ask for more information, you can still do so in the closing survey. All right, so I'd like to now welcome back our guest speaker for the live Q&A session. And I do want to let you know that a recording of today's session, as well as a PDF copy of the presentation, will be emailed to you in the coming days. So please use, again, the Q&A icon at the bottom of the screen if you have any questions. To see if we have any questions. Oh, we have quite a few here.
We have many questions.
Yeah, we do.
When may I answer some of them?
Yes, you can. Let's answer them now. Yeah.
Dr. Van de Putte from Belgium, I know him. I can share with him the article or the book.
Great.
Um,
Okay, that's great.
Doctor, the SLEB can be confused. The SLEB, no, it cannot be confused with the papillary dermis. We will differentiate very well. Sometimes the papillary dermis is so compromised that is completely occupied by the SLEB. Yes?
Karina, there was one question about Sandy was asking why T-mode doesn't work sometimes. So it should work. I mean, the T-mode is only available right now in the cheek, the temple, and the lips. But yeah, if you're having an issue, maybe reach out to our support department and see if we can get you straightened around.
Sorry, Shirley, when T-mode doesn't work correctly, we have to go to B mode and go after to T mode. This is like the Doppler because the ultrasound software made a quick reset.
Okay.
Yes?
Yes, and I also find too that if the T-mode's not working, maybe try to adjust your scanner position. It's almost a way to help you improve your technique a little. So if you don't have good contact or you're not perpendicular to the skin surface, the T-mode won't register as well. So yeah, if it's working and you get a good ultrasound image, then the T-mode it should work as well.
We have to do a correct orientation of the probe, yes.
Correct, yeah.
Another doctor, Dr. Velma, asked, when do you use color Doppler versus power Doppler? Power Doppler is better for very little vessels or slow velocity vessels. And for large vessels, color Doppler is better. But you can use both of them in facial structures.
Yeah, and I find too that the power Doppler isn't going to be as angle dependent. So if the blood vessel is running relatively parallel with the sound beam, the color Doppler will work well. But if the vessel is running across the screen, the power Doppler may be better, maybe a better choice. But try them both. Yeah.
Yes. Shirley, another doctor is asking which vessel occluded in patient with hyaluronic acid injection. In my patient, in my clinical case, the patient had an occlusion of the zygomaticofacial artery, and the embolus occluded also the lacrimal artery and the artery of the muscle. So that's why he had these clinical signs. Paralysis.
So what was the injection going to be infraorbital? And
no, the injection was in this side of the zygomatic area. This patient received a supraperiosteal HA filler injection, the needle, and the doctor caused a vascular occlusion of the zygomaticofacial artery. He entered into the zygomaticofacial foramen. So he occluded the zygomatic-facial artery and the artery of the muscle and the artery of the lacrimal gland.
Okay. There is one question from a very good friend of mine, Marianne. Hey, Marianne. How do you make sure there is only a single foramina before treatment?
How we may discover if the patient has only one foramina? We have to map the arteries or the foraminas before treatments. If we will to apply hyaluronic acid or other fillers in the supraperiosteal plane, the better option is to map the vessels or the foraminas before the treatment.
Yeah, and they're not difficult to see with the high resolution ultrasound when you know what you're looking for. Like once you've seen a few, you'll see them well.
Yes, to find a foramen is not difficult. We will see that the hyperechoic line that corresponds to the surface of the bone will be interrupted. And in this place, you have to put the color Doppler and be very patient, and the artery will appear.
Marianne is a sonographer, so she will figure it out. All right. Do you see another question you'd like to answer here, Dr. Ravera?
Yes, one doctor is asking if the amount of gel, we have to slide the probe on the gel, not on the skin. For having very good images, we have to apply 1 centimeter, for example, of gel.
But the gel doesn't affect the image; it just affects how well you see the image, right?
An important amount of gel, because the ultrasound cannot be transmitted on the air. We need the transmission through the gel of the ultrasound axis.
All right.
Another doctor is asking if there is any suggestion on it for the overheating of the probe. We have to use a fan.
Yeah, there's a little fan accessory that fits on to the scanner, and it's a great solution if you know that you're going to be scanning for a longer time and using color Doppler. I always just pop the fan on. Let me just find one here. It just it just pops on like this. Yeah, and I just put it on before I even start scanning if it's going to be a little bit of a longer procedure, and then once the probe gets to a certain temperature, the fan kicks in, and it can really help with longer scanning times.
I cannot understand this question from Dr. Sean Van de Putte. I switched from phone to PC regarding my question about the reference. We can write message.
Yeah. Well, if we didn't get to all of the questions, we'll definitely follow up with an email afterwards, either myself if they're a technical Clarius question, or Dr. Ravera if it's something a little bit more clinical.
Yes. Another doctor is asking if the Clarius may be used in arthrocentesis of temporomandibular joint. Yes, of course. You can see very well the temporomandibular joint very well under ultrasound examination.
Great. Okay, Dr. Ravera, we have lots of other questions, but I think we're over the top of the hour here, so I think we'll close things off right now. And as I mentioned, we will follow up with an email over the next couple of days if we didn't get to your question. So so please do complete our closing survey to provide your feedback so we can continue to bring you more educational webinars like today's. And I'd like to thank you so much, Dr. Ravera, for your insights and your expert ultrasound skills. And a very big thank you to all of you for joining us. Have a wonderful day and keep scanning. Thank you.
Okay. Thank you to you, Shaylee, and to the professionals that were here today. Thanks.
Excellent. Goodbye.
Goodbye.